Health in the Global South is a monthly session hosted by lecturers. Welcome to a very interesting session today. We will be discussing critical issues in telemedicine. We want to analyze if telemedicine is able to break the gaps we have within the health sector, and we'll be having this conversation with a very intelligent pharmacist who have a very in-depth experience, not just in healthcare, but also in data analysis and other areas. Mr. Okonkwo Lucky is also the program manager for autism, for effective autism Enugu. Thank you so much, sir.
Okay, thank you very much, Mr. Buchi. It's my pleasure to be here. I think the introduction was fine, right? Like you said, the program manager of effective autism Enugu, and today we'll be discussing telemedicine in the global south. Now, we want to critically reflect on equity and access. The question is telemedicine helping us bridge gaps, health access gaps, or it's just widening it the more? All right, so I'm going to share my screen now. Let's begin with defining things, right? So telemedicine is a subset of digital healthcare, and digital healthcare is healthcare using information and communication technology, right? So it includes AI, health apps, electronic records, wearables, personalized medicine. So we already know how AI is is invading healthcare. Any little question you ask AI, oh, what is happening? I'm coughing, will I die? And it's no longer new that we have devices we can wear on our wrist, and it tells us you've taken 1,000 steps today, or your BP is 120/80. These are all digital healthcare. But telemedicine now is the provision of healthcare services by health professionals. Most importantly, where distance is a critical factor. So the use, and it's still, like I said, is a subset of digital healthcare. So it involves the use of information and communication technologies just to exchange. The whole thing is exchange of information with the goal of helping the patients.
A quick break. We are working towards a target of 2,000 followers by December. We would greatly appreciate you join us on this mission of creating these contents to help innovators and medical professionals step into a room to discuss ways to promote better access to quality and affordable care. By following and liking our content, you would help us to be able to invite speakers that you would love to listen to as we grow. Thank you as you click that button. Let's get back to the show.
But equity is saying, who needs the money the most? Is it the guy with 10 million naira, or the person with 500,000 naira, or the person that does not have? So that's what equity is about. Equity is about bringing everybody to the same level, right? So the proposition of telemedicine now is bridging the gap. So where you can't go to the hospital, so instead of going to the hospital, stay where you are and reach out to the health professional. The status quo is that there are patients, right, and they face challenges like long distance to healthcare and limited healthcare workers. So at the end of the day, they can't access. There's delay in healthcare access. But telemedicine is saying, oh, instead of moving, just make the call, right? And you have everything sorted out. And look at it, there's, like I already said, there's limited skill providers. The truth is, in rural areas, in remote rural areas, villages, healthcare professionals are not there. They are underserved because, speaking from personally speaking, my preference, if I see an opportunity in Lagos State to work, and there's an opportunity to work and earn maybe a little higher somewhere in Borno State, Nigeria, I wouldn't go to Borno State because, or in a remote village in Borno State, because I will suffer from power outage. I won't get good water. You know, if I myself as a health professional fall sick, who will take care of me? You know, this makes access to skilled healthcare providers scarce for remote places in rural areas. So for them to access health, they need to travel long distances. It's not free. You know, they will pay money. It's costing them. And at the same time, there are no diagnostics in rural area. There are no diagnosis. The coverage is weak. Primary healthcare is weak. Overall, there's just system constraints in rural area. Now you'll be asking me, why am I just saying rural area? Rural area? Because I've already established from the fact that equity is asking who needs more help, right? So we are not focusing on just everybody generally. We're focusing on the people that really needs help now. But telemedicine is saying, okay, we don't need to deploy professionals to the villages. Professionals can be where they are and then connect with the patients in the village. So there's no need to travel. Consultation is faster. You know, instead of stressing workers that overworking them, you can refer, right? And then there's monitoring of remote monitoring. You can monitor BP, you can monitor their sugar level. These are things that are possible, that have been made possible with telemedicine. But it introduces a new variable in the equation, because before the advent of digitalization of health, what we have was social determinants of health, where you talk about, oh, people cannot access health because they are poor, because they did not go to school, because they are not working, their work does not provide health insurance. So these were the variables that existed before the whole digitalization came. But now with digitalization, there's now digital determinants of health. So this has to do with who gets included based on their access to technology. Now, instead of looking at who is poor, who is educated, we are now looking at who has internet connection, who can use phones, who have access to phone. You know, can they afford it? Is there light to even power these devices? You know, and language barrier. So the whole digitalization brought a new variable in the equation that causes a divide, right, between who can access and who cannot access. And in healthcare, there's a race to the last mile. What it implies is that there's healthcare, health services, and then there are the people who need them. The movement or the transportation or transfer of that healthcare to who really needs them, that's the journey to the last mile. So who really needs healthcare? You see that World Health Organization, they have a lot of programs targeted at people that are less likely to receive healthcare, people that are marginalized, people that are people with disability, the hard to reach rural areas. And then the truth is that these same people are the people that do not have access to technology. There's no electricity there, no device access, no internet connection. These are people that are not schooled enough to even know how to use phones. You get, and then it's now the case that the hardest person to reach with traditional healthcare is also the hardest person, or most likely the hardest person to reach even with telemedicine.
Sometimes you just need answers to some pressing medical questions and you want to be the queue at the hospital. With the advent of AI, this is so easy, but those systems are not built with medicine and your data privacy in mind. At Lectronit, we've developed Dr. Andre to be the trusted digital medical companion to give you answers to your medical questions in a trusted and secured infrastructure. Message Dr. Andre by visiting bit.ly/lectronit, that is bit.ly/LEXRUNIT bit.ly/lectronit and ask your questions for free. Link also in the description. Let's get back to the show.
So globally, the Isamjivani telemedicine is referred to as one of the successful implementation of telemedicine at a national level, and this is in India. Now, what they did is how India did theirs was during COVID-19, there was a lockdown and everybody was in their house and people were falling sick. So there was need for telemedicine. That's where the whole rush, this is where it's accelerated. There was need for telemedicine. So it was in practice, but not formalized. So India government set up a structure for it. So they came up with a Ayushman Bharat digital movement. So it's all about digitalization of healthcare. So see their architecture. These nodes, these are patients.
Yeah.
These are patients. Now, these patients can do e-consultation. So you go to the Isamjivani app, you create a profile, and you can consult with a physician from your home or wherever you are, right? But then for people who did not have digital access, who were not schooled, they could go to these other nodes here. These are primary healthcare centers.
Okay.
So they could go there and meet a primary health worker. And then the primary health worker would connect with a consultant or a more trained expert. And then the expert would interact with the patients, right? So they set up this architecture, this structure. So you can, from your home, access healthcare, or you go to primary healthcare centers and still access it. So it succeeded because it was government run, like it was run by the government, and it was a national platform. And it was not just telemedicine in isolation. It was incorporated in digitalization entirely. So they did this in addition or as a layer, as an add-on to their interoperability system. So they came up with a very, very complex system that allows communication between systems. And then it was free. It was free. So you don't have to pay consultation fee when you consult with any specialist. It was absolutely free. You just have to connect and do it. And it delivered hundreds of millions of consultations. So globally, it is referred to as being as a successful implementation of public telemedicine. So, like I already said, the COVID-19 gave it momentum, and the public ownership, it was government funded, it was free, and then there was high institutional trust because it was operating on the already existing health system. So it was more like integrated into it. So, and then it was not just one language. It was not just English or Hindu. It was, I think, 12 languages in the platform. Then the app had supported 9 languages. But even that, despite the fact that it is regarded to as being successful, it still did not resolve systemic gaps that they had. The same digital literacy barrier was there, even though they made significant success in this by redirecting patients to primary health care centers that will now connect to the professional, right? But they had challenge with inconsistent clinical documentation. So if you consult this doctor, the way he documents will be different from the way another doctor documented. So transferring data from one hospital. So let's say you see Dr. A today and you needed to use telemedicine tomorrow and you are seeing Dr. B. Your document with Dr. A will be stuck because of inconsistent documentation. So his software cannot transfer the information to the other doctor's software. That was a limitation that they had. And then they had triage issue. So let me refer back to this architecture. So if a patient comes here, he's referred to this level and or this level. So with massive adoption, patients were now being referred to, like the referral was now very much that they could not handle it. Triage is all about determining which condition should receive priority attention. For example, if there's an accident, somebody broke his leg, will be admitted into the emergency ward. If you have an asthma patient gasping for air, the person will be admitted into the emergency ward. If you have like a sickle cell patient in having crisis, they will admit the person into emergency ward. Now, triage is about who would I attend to first? If you are one person, who would you attend to first? Is it the person that broke his leg, or the asthma patient, or the sickle cell? So they had this crisis because the referral was much. So, and it just reflected the gap, the shortage of professionals that they had. And then there was governance issue, data governance. So the data in the system, who owns it? How would they manage it? Then I want to show us this picture. So you see what telemedicine does. The whole benefit now. So look at this family. They are waiting to be attended to. So they are experiencing long waiting period. But with telemedicine, they can stay in their houses and consult the doctor, right? And no need for waiting. The waiting hours has been reduced. But the question is, if you look at this at the window, you will see these people in the village. Their healthcare center is not even functional. So the people that could not access health before telemedicine are still the same people that cannot access health, even in the presence of digitalization, presence of telemedicine. So the question is telemedicine really bridging the access gap? Because at the end of the day, if these people were able to wait, they would access health, right? But it's just the waiting hour that has reduced or has been eliminated. But these people that actually need basic help, they are not getting it. So it's just like the telemedicine is helping people that could have been helped naturally. And then the people that are disadvantaged are advantaged. But the question is, should we stop building telemedicine? If telemedicine has this limitation, should we stop investing in it and focus solely on infrastructure? This is a really critical question. Should we just focus on infrastructure? Because if you look at it, the whole attention that is being given to telemedicine right now, the whole resources that is going there, these are resources that otherwise could have been used in increasing the number of primary healthcare centers that we have. These are attention and energy that could have been put in advocating for lights, advocating for good water, good road, for security. But everybody's attention right now is on telemedicine. And if you understand opportunity cost, you will know that building telemedicine is saying, in a sense, let's reduce getting infrastructure right, and let's just channel our energy towards telemedicine.
Yes.
And like we've already seen, telemedicine is helping people that would most likely have been helped without it. So, but it will not be able to just focus on infrastructure, because the truth is that technology has come to stay. So we need to integrate both physical health system and digital health expansion, so we can have a solid system. Like the Isam Jivani is regarded as being successful because of the reach. They recorded millions of consultations using the telemedicine. So it expanded the reach, right? And data showed it. But the limitations that the infrastructure had, technology inherited it. It was not, it's supposed to be an expansion, not an inheritance of the inherent limitation. So telemedicine should complement health system, not compensate for weak ones. Because technology it will come and rest on what we already have, right?
Yeah.
So we should, at the same time as there's development in telemedicine, there should also be improvements in reliable electricity. We should have internet connection. We should have good roads. Primary healthcare facilities should be functional. There are places in Nigeria that the primary healthcare centers don't have anything. As in, you will go there and you'll be so disappointed at the state, and people don't trust it, because what's the point going there? And as a matter of fact, people don't even know that there are primary health facilities where they are. What they are aware of is a private hospital or a federal hospital, a state hospital, a teaching hospital. They're not aware of the primary healthcare centers around them, because they don't have trust in it. Nobody is saying, oh, you're having malaria, go to the primary healthcare center there. They'll tell you what drugs they have, they'll give you substandard drugs. So these are things that have to be in existence, that have to be functional, because this was what made Isam Jivani successful. They strengthened their primary healthcare centers and then made it contact points for people without digital literacy. So video consultation, electronic health record, while these things are growing, there's also need for strengthening the health system we already have, especially in Nigeria. And not just these things that are listed here, but most importantly, security. These are things that it spans beyond just healthcare into a larger governance thing. You see, but we can do the most we can, right? They say do what you can where you are, using what you have. So if what you can do is helping the people you can help, which are the people that are digitally literate, you can start thinking of innovative ideas. Okay, how can I develop a digital healthcare product that can serve people in the rural area? You see that? So you start thinking in that direction. These are for developers.
Sometimes you just need answers to some pressing medical questions and you want to be the queue at the hospital. With the advent of AI, this is so easy, but those systems are not built with medicine and your data privacy in mind. At Lectronit, we've developed Dr. Andre to be the trusted digital medical companion to give you answers to your medical questions in a trusted and secured infrastructure. Message Dr. Andre by visiting bit.ly/lectronit, that is bit.ly/LEXRUNIT, bit.ly/lectronit, and ask your questions for free. Link also in the description. Let's get back to the show.
So the future is we build technology, we build infrastructure, and we are building with equity in mind, right? Even as much as we are supporting people in the urban area, reducing waiting hours, increasing access for them. You should build the with the last mile in mind. All right, so I'll just end with saying that telemedicine in the global south requires architectural intention. We cannot only code our way out of physical inequality. We must build digital solutions around the communities that already exist. Thank you.
Wow, thank you so much, sir. Thank you. That was a very wonderful and broad um, session. So I would like to think of situations like, let's use Nigeria as a case study in this like interactive session, and think of, we know that um, let's say most, if you look at the way that many innovations in the private sector works, is that a lot of private companies are looking at the gaps of where there is gap, and let's say the government has not been able to fill that gap. You see companies or people coming out to think of how they can build a solution around that. And then we also see people try to cover the gaps in, let's say, for internet access, for instance. You see some people use Starlink. There are some other companies spanning up like Southeast Connections and all of that. So in this healthcare sector, where you see that infrastructure is very important, but yet to be able to build those infrastructure, we would need we need if the government is not like covering that in the country, we need to be able to have people in the private sector coming in to help. But then when people in the private sector comes in with solutions, let's say in the case of like Starlink, for instance, you have to spend a lot of money to acquire those infrastructure and a lot of money to maintain those infrastructure. How do you think in telemedicine, for instance, what do you think can be done in infrastructure? Do we wait or rely on the government, or do private companies? How do we like balance that?
Okay, so if I get your question right, you're saying that private how should the private sector handle the initial cost of setup? Is that what you're asking?
Yes, in a way that the hospitals can be able to adopt, hospitals, patients, and local healthcare centers could be able to adopt solutions to help them have like a better infrastructure for their use case.
Okay, so I want to think of it like how NGOs are supporting current healthcare problems in Nigeria, for example. So they get fundings from donor organizations, big organizations, and implement what they want to do. So in terms of telemedicine, right, one approach that I have seen is partnership. I've seen a telemedicine provider that partnered with that partnered with um, NHIS, or they are trying to partner with NHIS so that people can consult them for free while their health insurance take care of the costs. So these are approaches they can other developers too can use, but it will raise the issue of data governance again. Who would own the data? And government cannot release the data of everybody in their database to them. So at the end of the day, it comes down to the government setting infrastructure for others to ride on. You see it now. And another thing providers can do is partner with hospitals, partner with private hospital, government hospitals, secure fundings, establish your establishment, and then partner.
Uh, Okay, so building on top of that question, I think one thing that is very much neglected is the health professionals themselves. I'm in a community of medical students, and last this week, yeah, there was a conversation around who is more at risk in a hospital. So if you're in a hospital, who is more at risk? In telemedicine, when I see a lot of conversations online, I don't really see people talk about the medical professionals also. You know, one of the doctors we are in contact with for adoption of our hospital management system, the problem the doctor had specifically was the fact that now we want now the platform may be able to bring more patients, like they may be able to have like more inflow of patients, but they still have the number of staff that they had before they started using the platform in the hospital. And then now, how how do hospitals manage that in advent of telemedicine? When they adopt telemedicine, they have more patients coming in to join them. How do they actually manage that balance? Does it provide pressure to the hospital? Do they like need more staffing? um what is it like, what is it like within hospitals or pharmacies when they adopt this kind of system? How does it affect their current structure, especially for those that fully uses paper and pen for recording, and they have large files for every patient? How does how does this affect them?
I love this question. I love this question because it highlights a gap that, like you said, is overlooked, right? That telemedicine did not bridge or has not bridged yet. Because at the end of the day, after the consultation, you might be referred. So the whole thing of not having to travel, not having long waiting hours is in a sense defeated. The only the only advantage is that you might take theoretically is that if everybody's consulting, then the number of people that will physically be in the hospital will reduce. So when they now refer you, you will not meet much people. But we don't know that yet because it's just a theoretical assumption or a proposition. You understand? So it doesn't take away the need for trained professionals. Telemedicine does not do that. And like we saw with Isam Divani, they also had triage issue. And triage issue would come up when you are understaffed or there's high demand per time than professionals can meet. So if 5 people consulted via the telemedicine app and they are referred to the same professional, those 5 people will still meet, they will meet themselves and wait. You see it? So it does not remove that gap. And this is one unintended consequence of the whole pro telemedicine thing because it's shifting our attention from the need for more trained professionals, the need for us to retain them. Because the truth is that, using Nigeria as an example, the amount of brain drain going on in healthcare is mind blowing because everybody they are living. Everybody, whoever has the opportunity is living. So the few ones that are there, they will be overworked, they will be stretched. And if you now direct your instead of saying, oh, we need to retain our health professionals, we need to train more of them, we need to make this place conducive for them to stay, we need to increase their pay. Instead of doing this, you are saying, oh, let's all embrace telemedicine. It will still boil down to the same thing, the same triage issue, the same waiting period, the same high doctor to patient ratio.
Yeah.
So yeah, that's it.
So I'm also thinking that, is this not like a structural problem? Because not, how do I put the question? let's say if let's say in let's take the first world, for instance, like US and UK, those countries, most people there, if most major hospitals or like let's say most hospitals there, they are almost fully digital. Their patients use a lot of like digital tools. Because one doctor once was complaining also that most people that come to the hospital, that like sometimes people just come to hospital for very little things, or just for simple complaints or for simple questions. And then sometimes those things are things that they could have just told them from home to just do this or do that. And then if you look at, I've been for eye checkup once, and my file in the hospital wasn't there again. I have to make new payments, get a new file, and they have to do test again. So if you are looking at here, let's say there is so much noise around telemedicine, but I also feel like there is a lot of hospitals that still rely on pen paper kind of system. They still have like a lot of constraints in the data management, the data security, and things like that. What do you think is the major reason that a lot of hospitals in Nigeria is not using is not digitizing their hospital? They're not using digital tools. They still rely on their pen paper. They still ring bell for nurse to come and take orders, or for nurse patient for consultation to come in. Why do you think we have that still in place?
So I would just say for private hospitals, right? I will boil everything down to not everything, but a significant part of it to cost, the initial cost of setup. Who is going to bear that cost, and what is the benefit to them as an institution? Because while we are looking at healthcare as humanitarian service, right? There's also business in it, right? And in business, you weigh your profit and costs, right? It's not like they don't know that there's a need for digitalization, but how would they get the money they invest in changing system? Because if you have the truth is there are the archive room, not just a cabinet now, room. You see a lot of patients file. For you to translate it to for it to become digitalized, you have to manually input those things, right? You have to say, okay, for example, let's use your case now. So the hospital you went to for the eye checkup, if they want to become digital now, all your file, your folder, they will need to enter it into a system. You agree with me, right?
Yeah.
And they will need human beings to do that. They will hire people to do that. They will pay those people. So how much profit will they make from when they become digital? How much profit will they make from it? That's on one hand. And setting up the infra, and then knowledge also contributes. Knowledge, they can't see how they will benefit from it, right? So it's just there's need for advocacy in this regard, the need for digitalization. And trust me, if government hospitals take the lead, private hospitals will follow suit. But if the government keeps lagging behind, and all that matters is just the next tenor and everything, everybody will relax. And there's just need for advocacy for it. They need to be aware of the benefits, right? And the truth is in Nigeria right now, in as much as online there's a lot of noise going on. This is not statistics, right? I'm not saying, but from experience and what I'm seeing around, I don't think up to 20% of hospitals in Nigeria are digital. They are not.
Wow.
And moving is a lot.
So we still have a lot of work to do. It's not just there's need right now. Right now, what's going on? Right, they are holding summits and conferences, and they are discussing the need for establishing an interoperable system in healthcare. So these are the kind of discussions that will precede digitalization at the end, because there needs to be interoperability before everybody goes digital. Because, for instance, if I think I said it during the presentation, if the first hospital you went to, um, okay, let me just give a very, very simple example and then I'll end. You're on WhatsApp, I'm on Telegram. You're using WhatsApp, I'm using Telegram. You can't send. We cannot text. You have to be on Telegram for us to text, right?
Yeah.
Or I have to be in WhatsApp for us to text. So if if there is not a system that can bridge, that will make it possible for you to send message from Telegram to WhatsApp, if it does not exist, we will still face the same challenge. We will still face the same challenge of starting over again if you go to another hospital, because this hospital software cannot interact with the other hospital software. So that's the whole thing for interoperability. So it's not just even digitalizing. Is for hospitals to be able to communicate.
Mm.
So yeah, that's it.
Wow. Thank you so much for the presentation, for the insightful responses to all the questions. We would like to have you again very soon. Thank you so much for the words of wisdom. Thank you to everyone listening to this session. Thank you so much, sir.
All
Um,
right. Pleasure.
yeah. Health in the Global South is a monthly session hosted by a steadily growing health company. Let's run it. Thanks for listening. To partner with us, mail info@lexrunning.com or visit our website lexrunning.com. Thank you. Don't forget to like the video and subscribe to the channel. See you next month.